start with, I'm going to ask everybody the same question. I'm just going to ask you to respond, I suppose, to both what you've heard this morning from the professor and also from Becky. So just looking at social determinants, their impacts on the health outcomes or future health outcomes in your worlds. I'll start with you, Tanya, and then yeah. I can go the other way if you prefer me to. Yeah, okay. I'll come back to you. I'm going to start here, if that's okay. So just response to really what you heard this morning.
Can you hear me? Yeah. I thought this morning was just amazing, really. It was just great to hear really relevant information. And, you know, it's nothing that we don't know, but it's great to hear it put together the way it was. You know, I think we've got great scope to develop children's services and particularly health, etc. So I'm going to say more later.
Okay, great. I'm going to pass the mic down again.
Hi, thanks. It is really great to have Michael Marmot in the room. I think I think we've all been students of his work over the last, I won't say 50 years, but anyway, and it really does resonate with the work that we're doing. I suppose in Cork and previously, I've worked in marginalised communities in neighbourhoods as well as marginalised groups across the life cycle. And I suppose in areas that I work in, we see adults with poor ill health, very, severe ill health, disabilities and early death. I even go back to a photograph I have of a women's group, and I'm not a tall person. And these people are at least a foot below me, and that is a sign of intergenerational poverty. And so children that are born into those situations, which we see through our work in Let's Grow Together, are born into households where there is ill health around them to the degree that people aren't able to work. There's overcrowding in houses, and that impacts their relationships and their development. So by the time they're reaching school age, inequalities are deeply entrenched. And but like Michael Marmot said, it isn't determined, and there is so much we can do and are doing. And we see, the trajectory of children born into these situations changing as a result of the right intervention at the right time. So we do have to hold on to that and grow that as well. So it's a great honour to hear what we have today and to hear the mention of the Kidscope Clinic, which I'll talk about later.
Yeah, great. Thanks a million.
Thank you. I think from my perspective, I've been a nurse for over 30 years. Most of my career is spent in acute hospital services, predominantly working in cancer services. And, I think we've always known as nurses that social deprivation leads to poor health. But we didn't 30 years ago, certainly when I started my career, I wouldn't have had the words to describe what I could see or how to talk about it to somebody else, but we just knew that it was there. So I suppose now that I'm working in the Department of Health and looking into policy and trying to help build policy, it's really important that we look at all the evidence and the research that's there to help us build the policies in the right direction. We look at things like the WHO policies on social deprivation and equity for health. We look at even Healthy Ireland and how they're monitoring social deprivation going forward. So I think for me, it's been a huge learning curve, but lovely to have the language and the words and the evidence around it now to bring it into policy and hopefully do something better for the next generation and for generations to come.
Great. Tanya.
The first thing is about being persistent, and what I mean by that is the Children's Rights Alliance team had sent 4 invitations to Professor Marmot over the last 2 years, and finally he said yes. So I'm really delighted that he was.
I did tell him it would be easier to say yes straight away.
I was really delighted, and every time the team would say, I said, is he going to say yes? Well, let's try, and they were right. So really it was brilliant to have him here, because it's the most compelling analysis of health determinants. And as you say, it's what we all see in the work we do. It's in the communities that we grew up in. It's across the country. And what was really compelling for me is political action, because what you can see in that story of the data is what happens when politicians change. And when they decide to cut things and they decide to undermine things, you can actually see it actually has such a major effect. So if we take it the other way, that means political action works. Actually, it does work. And what I've been very hopeful from Professor Marmot's put, and also from discussions we had with him earlier on, is actually how in Ireland we're going in a different direction. I'm pretty proud about that. And I think one of the things about that, I was kind of thinking about it as he was speaking, there's something about the people in this room, there's something about the people in the Department of Taoiseach, there's something about people in government departments, something about in all the sectoral organisations and the foundations, everyone is on the same page and working together. And actually we've achieved a lot, even though if you look at the political makeup, it's been political parties in power who've been right of centre, that's very meaningful. We have done a really good job, but we have so much more work to do, is the truth of it, and you can see that from the data. And I suppose what I'd love to see is, okay, what's next? What are the key measures that we back that are going to break the cycle? I'd love for us to be the country that's like Denmark, that we can break the cycle in 2 generations. Why not even 1 generation? Because we know lots of people that have broken the cycle in 1 generation. That's because of some intervention, some service has done that. I'd love to give every child the chance to really give them that chance to break the cycle.
Thanks, Tanya. So, Becky, I'm going to come back to you on that that call, I suppose, to action that Tanya has just put out there. And just based on your own research and your own work, what do government need to do, or what would leverage government into developing a dedicated public health service for children and families, in your view?
Can you hear me? Yes, you can. So, I think this the sort of energy and enthusiasm in this room is a really encouraging place to start. And I think the mention of the programme for government is a really important place to start. I guess, from my perspective, there's significant building blocks that already exist in the Irish context, which is huge. We already have a very effective public health nurse service with effective training that is really dedicated to doing right by the public and recognising, as we've spoken about, the impact of deprivation on people's lives and outcomes. For me, there are a couple of different aspects that need to be considered. So, one is a meaningful expansion of sort of community health centres in Ireland, through which public health nurses can be attached, where they can be supported, where they can commit work. It's something that is really crucial. And they can be important in terms of providing wraparound services, not only in relation to public health and GP and paediatric health, but also in terms of connecting families and children within their community. We have a tendency in Ireland, at least at a policy level, sometimes we speak about community and we label things as community, but these health centres need to actually be sort of community hubs in a lot of ways, and in the ways that many of you currently practice and speak about. So that would be one thing that I think is crucial. But equally, and as a sort of a social policy wonk, governance is a big issue. So there needs to be political will. There needs to, because child poverty has been spoken about, that has been spoken about for decades in the Irish context, is something that has been highlighted as an issue, as something that is morally wrong. It is wrong that there is such a high level of poor children in Ireland and the impact that that will have on their later lives. There needs to be political will, and in many ways, a recognition that childhood poverty needs to be detached from ideology. It should be considered unacceptable in a wealthy country. And finally, that sort of ties into, I think, the point that Tanya made. There is a lot of people working across departments who are committed to this vision, but there needs to be a coordinated effort to actually think practically about how that can be achieved. Because I guess a lot of the sort of strategies and reports that we read speak about goals in a way that make it quite difficult to action them. So there needs to be sort of concerted effort to think about actioning them, and I think that is about placing healthcare and education within the centre of every community. It needs to be tied in. So thank you.
Great, thanks, Becky. Jackie, leading on that then, you're leading the HSE's public health work in Dublin North City in the West. Just talk about the role of public health nurses to kind of complement Becky's research in terms of responding to complex family needs.
That's a good question. I work in the North Inner City, and it's an area, like we have a very mixed area, I suppose, really. You know, the areas that I would cover particularly would be Ballymun, right into the North Inner City. So, you know, the concentration in the North Inner City of children who are living in homelessness is beyond anywhere else in the country. You know, like, on a monthly basis, we get stats of children who are exposed to homelessness, and 60% of those will live within that North Inner City, that Summerhill area. And I suppose that in itself raises its head, raises concerns for us on a daily basis. We recently audited our child health records, and Fiona Chancey, who's not here at the moment, Fiona, I think she was here earlier on, but she led out on research, or on the audit that we did of our child health records. And the results of that would show that children who are in alternative accommodation, meaning homelessness or indirect provision, are twice as likely to be referred to a service. That's enormous. That's feeding into what we were talking about this morning, and you know, and then and of that as well, 4 times more likely to be referred for social emotional support. And that's where our colleagues come in early years, and how we depend and work together with our early years supporters. Our public health nurses are essential, really, day-to-day essential. There's another report that I went to, or a launch of, if anyone's here from Focus Ireland, I went to a launch of the work from Focus Ireland the other day, and it was really interesting. It was about mothers living in homelessness, single mothers living in homelessness, and their own, no prompting or anything else. What came from that, their own, unanimously, their own thoughts were about, or I suppose their own, what's the word I'm looking for? Their own expressions really were about their public health nurse, how important their public health nurse was in their lives, which often goes really underneath. It's not ever exposed, or it's not ever spoken about. Public health nurse is in the background. I've often been at meetings where we're talking about something quite, you know, global and concerning and everything else, you know, or we're talking about homelessness, we're talking about traveller health, whatever, and I have a public health nurse on the phone. I'm silencing the call, and I'm taking a call about something that's happening in an area, and the public health nurse is involved in that. Nobody knows that, you know. And for me, it's also those links. We link so closely with our allied professionals. That's really important. So we absolutely need public health nurses, but we equally need access to supports. We need to be working together, pulling together at every level. I think I learned from the best over there in relation to working together, Francis, many years ago in Tala, where we worked together, and that made a difference, you know. So,
Great, thanks a million. I can't let the mention of Focus go by without paying a little tribute to Sister Stan, who we lost this month, who was relentless in her pursuit of social change and just never gave up, never ever gave up. So anyway, just to acknowledge her great work in that. Gráinne, if we were going to step back and look at the concept of a child health workforce, how can it be developed? Are we in the right place for it? What are the critical steps that could be taken?
So it was really good to hear Becky's research findings, because we've done something quite similar ourselves. Obviously, the first 5 was written, I suppose, and published back in 2018, 2019. And one of the recommendations is to develop a dedicated child health workforce, specifically with a focus on making sure the National Healthy Childhood Programme is fully rolled out. So late 2019, early 2020, we set up a steering group in the Department of Health. Unfortunately, a global pandemic interrupted progress, but we reformed the steering group in 2023. And part of that work, we didn't just look at the public health nurse role. I think probably from reading the first 5 was predominantly focused on the public health nurse role, but we took a wider slant, and we looked at all child health care workforce to deliver on the National Healthy Childhood Programme. So a couple of steps. We engaged with the HRB, who did a scoping exercise quite similar to the one that Becky showed. We looked at 3 countries. We got an evidence brief, essentially, and we looked at all the dedicated professionals in health that work with child health. predominantly the public health nurse role is a theme that comes up. We looked at Scotland, Netherlands and Sweden, and we could see the common theme is the nursing role. And usually that nurse would have a little bit of further education at postgraduate level to support them to be able to practice. But some other countries had other professionals as well, maybe dedicated doctor roles, dedicated psychologists, etc. So looking at the evidence brief, we then did an exercise around Ireland to see what do we have nationally. And there's several really positive things, like, public health nurse is the key in delivering at least five visits on the National Healthy Childhood Programme, the developmental and health screening. And we could see that sometimes when referrals onwards are required, you need a whole suite of health and social care professionals to deliver on some of those. And again, Becky spoke about some of the waiting lists that happen at those points. So community medical doctors are key as well in helping with those health interventions that are required. But typically considered second tier referrals, public health nurse being the first tier. And so we compared, I suppose we did the whole scope and exercise following the National Healthy Childhood Programme to see where the issues were. We know that Children's Disability Network teams are dedicated to children, so that's really good. CAMHS, they're dedicated to children. We don't have public health nurses dedicated to children. We don't have community medical doctors dedicated to children. And we don't have health and social care professionals working in primary care settings dedicated to children. So a couple of recommendations stemmed from the report. We've compiled a report, sent it on to the Minister for Health and the Minister for Children, and we're now working on the recommendations. So one of the first recommendations is that, and again, Becky called it out there earlier, the public health nurse role currently is a whole lifespan, and where you look at the cradle to grave. So it's very difficult to untangle that unless we do something different. Currently, there's another suite of work going on through the Chief Nurse's Office looking at the framework for safe nurse staffing and skill mix in various care settings. And it started, approximately 10 years ago, looking at how do we know how to calculate the number of nurses required in X setting. The first setting looked at acute hospitals in medical and surgical wards. We now have calculations on how to predict how many numbers of nurses we need for those. We have calculations on how we can deliver nurses in emergency departments. We're moving into the next policy space looking at long-term residential care settings for older people. So we will have calculations and a whole policy coming out on that fairly soon. So the next piece of work that was going to be done as part of that whole programme of work was moving into community care settings. So what we said was, okay, we would like some public health nurse roles dedicated to child health, but we need a way to calculate how many. And if we take public health nurses away from maybe care of the older person or some of the more, I suppose, adult services that they supply at the moment, how do we know how many nurses to replace them with? How many community RGNs? So that work is now underway. Again, we like to have all of our policies evidence-based. We've engaged a research team who've already, throughout the summer, have been getting baseline information from public health nurses, community RGNs, directors of public health, etc. So there's a suite of information there. And we've recently just set up an expert oversight group to progress that work. And we'll, working with the research team, we'll pick some pilot sites and the research team will go in and start testing. But what we're hoping to get at the end of it then is, I suppose, a way of calculating as part of the framework, what do we need, where do we need it? Now, as an aside from that, part of the steering group are also, there was a couple of projects, I think 3 years ago, they got Sláinte Care Innovative Funding to look at health and social care professionals in primary care settings. So there was 2 projects. We thought, okay, we're not going to reinvent the wheel. This is really good work that's been done. So we've linked up with those to follow, and Pobal, I know we're doing the reports for those, to follow what those projects look like, what the good outcomes are, to see can that feed into recommendations for health and social care professionals. And we've also then engaged, we were in the early process of engaging with community medical doctors to see could we have some community medical doctors specialised. So hopefully when all of that work is done, we'll have a much, I suppose, much better guidance nationally on how we would have an entire dedicated child health workforce, but specifically including public health nurses as part of that.
Great, fantastic work. Yeah, sounds fantastic. Catherine, I'm going to come back to you, and you alluded to it earlier, but the Let's Grow Together team has collaborated with Dr. Louise Gibson in Cork University Hospital around the paediatric clinic. Will you tell us a little bit about the initiative and just the suite of services?
Sure. So Kidscope was actually started in 2010. And Louise Gibson, in her mind, I think, thought it would be an experience for medical students to get a real-world experience in community settings. For me, it addressed a really serious need within the community for children to access needed healthcare services for them. So I suppose the two agendas merged then, and this clinic was set up then. So just to walk you through a day in the clinic today, from then, is that the PHN, so our public health nurses locally, are the referrers into the clinic. So they're absolutely an essential first point of contact. And any developmental need that's identified by the family or the public health nurse can be referred into the clinic. For a child aged 0 from birth to age 6 can be referred into the clinic. And families come into the clinic then in a community setting already established in the area. So, you know, that kind of trust has been mentioned. That sense of trust, relationships, familiarity is already there. Families come in together, they're met by a community worker, the administrator, who really models that relational approach, and they are assessed by the consultant paediatrician, along with community medical doctors, PHNs and others, using the ages and stages tool, using their own observations, taking family histories, and these kind of things, and a kind of an assessment, I suppose, of need is made there as a response. And at the end of the clinic then, the whole team, together with their social and community partners, so our team in Let's Grow Together, who provide parenting supports for children in those earliest years of development, and our local Tusla Family Support Project as well, coming together with the, I suppose, allied health professionals to work out the responses that are needed for the family. And then they are brought back into the clinic for a review a little bit later in the year. And I suppose what's happened, the clinic itself was subject to the research study, IRC funded, that has, I suppose, provided its evidence base that children who are seen in the clinic are intervention and diagnosis happens at the earlier stage of development. And even, you know, thousands, I think nearly 3,000 children have been through the clinic at this stage. And I suppose it's really important to note. Well, I hate using the term, but I'm just going to use it anyway. The do not attend rate is virtually none, because we're able to provide, you know, in the last academic year of the clinic, 4 families didn't attend, you know, and over 100 and something appointments were made. So it really is down to the local context and the local piece. And now we have clinicians such as audiology, speech and language, CDNT, PH, all working together. And I just want to say something about that as well. That's really motivating for that workforce, that there is peer support across disciplines. And I suppose I'm the non-clinical actor in the whole thing. And I suppose to see them all talking to each other, round tables, supporting families in a timely manner, it breaks down the silos between them as well, and it really improves the service delivery and output for those families. And then also when they're back in their own workplaces and you know, able to pick up the phone to each other. So it's having a huge ripple effect. that kind of MDT approach. And then the other thing I just want to say about public health nurses is within our own, so we're funded on the National Area-Based Childhood Programme, and I think it's really important to mention that that is our Sure Start model in Ireland. National anti-child poverty strategy, providing prevention and early intervention supports in Ireland, and there isn't enough of them and there isn't enough of it. And you know, when I looked quickly at the populations levels this morning of the children in Ireland, 0 to 4, I think, you know, 40-odd thousand in Dublin, 20-odd thousand in the Cork region, 20-odd thousand in the Galway region. I mean, for a state, these aren't huge numbers. And I think if we want to think about prevention and early intervention and meeting children where they're at and intercepting intergenerational poverty, these are the type of initiatives we've got to think of. And public health nurses are absolutely critical to that pathway. 90% of families who register with our services are being supported by the public health nurse to do so. So again, you can see the kind of marrying up between community services and public health nurses. We're all training together, we're all working together, and that I suppose enhances the experience of the public health nurse. I think you're talking about the very difficult role that they have, and having these wider supports that they can tap into supports their work, I think.
Brilliant, thank you. Tanya, I'm going to come back to you. Children's Rights Alliance obviously have been doing considerable work on the issue of child poverty. You know, when I think of Child Poverty Week, the Child Poverty Monitor, the No Child 2020, you know, really putting a focus on it.
A lot of which you funded.
So
So thanks for that.
You're very welcome. So where are we now? And just with the propositions that are being put forward today, just give us your view on where we're at.
Yeah, I mean, I suppose one of the amazing things about working in this space when we started off is just the amount of people who are part of the conversation now. And there have been some game changers. I mean, one is the, you know, really the great support of funding from the Community Foundation and the Catherine Howard Foundation to keep us working on these issues, to keep the same team working on child poverty issues day in, day out. That has made an enormous difference. But what has been brilliant to see is just this wide collective of organisations who are all working to the same goal. And you know, the game changer, I think, is definitely the child poverty unit in the department of the Taoiseach. And why it's a game changer is because one thing we could see after the recession was you talk to civil servants and they all cared about what was going on, but nobody had the bandwidth to actually coordinate and work together. And you know, and we asked questions of ourselves: do we need another combat poverty agency? But actually, when you talked to officials internally, and when you looked at models internationally, what you realised was actually government taking responsibility and implementing is actually generally the best effective model to do it. And of course, we can all do the accountability piece on the outside. So I think that's a game changer. That has changed the conversation. That has brought a lot more people into the discussion. And you can see organisations, public organisations, representative bodies, all of them part of the discussion. So something, you know, very special has happened in this country when it comes to child poverty, and everyone is taking an interest, including political leaders across political parties. That's all very positive. What you can see is, I think, and what's really important is, child poverty is not going to be fixed in about 5 budgets. It's probably going to take about 10 budgets, 10 years of action at different levels. And you can see in each and every budget, you know, different adjustments are made that have made a difference. Even if you look at the statistics, obviously they're very stark. We've already seen from Rebecca today and Professor Marmot. But there's other statistics that showed if we didn't implement the measures like free school books, hot school meals, the figures of children in consistent poverty wouldn't be 5.9, it would be 13.1%. So a lot of the measures actually that the government have introduced over time have worked. And it's great to see, you know, some recognition internationally that the Irish government is actually going against what other governments are doing, including our friends in the UK and including our friends in the US. And I do really feel it, you know. It's so dispiriting to watch what children are experiencing in the UK at this moment in time. I often think, what can we do to reach across the water to work with our colleagues? So I think where we need to go is we need to focus on what are the absolute key measures that are going to make a difference. And we already know, even listening to the panel today, it's pretty obvious a public health-led nurse system based in a community is delivering the best possible outcomes. The government needs to make sure that that happens, that every community in Ireland has access to that. We already know in the area of early years education and Equal Start, the Equal Start programme, the equivalent of Sure Start in the UK, we know from the data that's going to have the same kind of effect. So what we need to see are these measures being backed and heavily invested in and rolled out. This is the kind of the future, I think, of our child poverty work, and we need to stick with it. We're going to have to work together to keep this on the agenda and make sure it doesn't fall off the agenda. But you can see things change, right? Things change very quickly in political circles. But I do actually think it's part of, if you think of the wider discussion around anti-democracy, you know, the disturbance that's happening in our countries across Europe, the answer is addressing child poverty. And I think we all have a really critical role to play in relation to that.
Brilliant, thanks, Tanya. I'm actually going to go to the floor now. If anybody has any comments or observations, Francis, I'll do a few and then I'll come back to the panel.
Yep, Francis Jansen, a board member of the Children's Rights Alliance. It's great to hear the updates of what's happening in terms of the future development of public health nursing from Rebecca and Grania. I suppose alongside that, we're seeing frequent media reports over the last 5 years of vacancies in public health nursing, of parents getting letters to say, if basically, monitor your own child's development. If you're worried, go to your GP. And that's, you know, in a situation we have the National Childhood Programme and we have all of those structures in place, it's just not acceptable that that's happening. With my suspicious mind, I'm suspecting that that is happening more so in areas of disadvantage than areas of advantage. And relating back to Professor Marmot's input earlier on, without pushing a political point, I think the political point is pretty obvious that our investment in children of advantage is greater than our investment in children of disadvantage. So I think there's a really urgent need to move on the child and family public health nurse. We've been talking about it for a long time. It was piloted over 15 years ago in the Midlands by Virginia Pye at the time, piloted there. It was very popular for the public health nurses who went into child and family public health nursing. It was also very popular for the public health nurses who looked after care of the elderly and end of life care. So I think it would be a contributor to retaining our public health workforce. The Sláintecare report, the very first recommendation of Sláintecare was the workforce. They calculated and they costed the number of posts required. And I suppose it's a little bit frustrating that we're still calculating and we're still costing whatever it is, 8 years since that report was written. I know we've had a pandemic in between. First Five broadened the discussion into the whole child health workforce. My own thought would be, let's do it with public health nurses and then let's roll it on to others rather than trying to do everything at the same time. I really think there's an urgency in moving forward with this. So with that in mind, I would just to ask both Rebecca and Grania in particular, what's a reasonable time frame with a fair political wind behind us to have the first pilot up and running and all going well to having a full child health workforce in the public health nursing service as recommended by Sláintecare, as recommended by First Five. We have it in policy, we just need to implement.
Great, thanks. I'm going to take a few if that's okay. Here we go.
My question's coming from two sides. I work with homeless families in Cork, and we're very familiar with Kidscope and the wonderful work it does. But I suppose my easier point, and I don't often talk about the positive side of homelessness, but just in this example, you know, sometimes families who come into our services, particularly to our supported emergency accommodation, because they're meeting professionals and we have social care staff, we can expedite the process and get them referred into the clinic and seen with Catherine's team and all that. So that's good. And in situations where families are going into B&Bs where they can get the support, it's a voluntary service. If they want the support, we can help. But I'm just thinking of a situation of a family who moved into B&B and there's a little boy and he's now in 2nd class, so that's 7 maybe. He had no developmental checks done. So like this was the positive upshot of him ending up in private emergency accommodation, which subsequently created its own problems later. But that child had no developmental checks. Now, the child was a child of a young mum. I think she might have had him when he was 17. She was doing absolutely the best she could and she had a partner, but nothing had been done. How was that missed? And like, there are loads of those cases of children in the community who are what we'd call, you know, Tristler's always talking about it, low risk, high need. We're just not getting to those families. And there's been a colleague who's often at some of the Children's Rights Alliance events, I think it's Josephine, always talk about home visits, and I don't know if that can come into this. Why aren't we doing more home visits to get in a supportive way to meet these families in the community? And then, so that's one aspect. But then, you know, when I listen to Jackie talk and, you know, over the years, myself in home service, here we are and we're just adding to the complexity of issues being pushed back into our health system by having thousands of children in inappropriate emergency accommodation and direct provision. And, you know, I just don't know if people realise how bad it is. In a report I filled back, the examples I gave of families not being able to clear scabies infections because of the cramped conditions in the bedroom. Blood-stained mattresses that families were moving into. You know, so they're like the shocking ones. But we need public health support to children and professional support to children who can't sleep because of the environment they're in. These wouldn't be sleep problems they'd have if they were in a safe home, you know, like a proper home. Nutrition. So we've obesity, fast food, and play. So you're talking about then your social and emotional regulation. So we're just churning out a production line. And it's not the children's fault, but we're creating problem children by not addressing the state of the emergency accommodation for children in homeless services and in direct provision. So they're just the two angles I want to put forward. Thank you.
And there was somebody over here. There we go. And then I'll come back to the panel.
Thank you. Anne Pardee, I'm Programme Manager with the HSE's National Healthy Childhood Programme. First of all, thank you. If Professor Marmot left us with hope, I'm sitting here feeling very energised. And I think that's what we all need because, and actually particularly listening to that last question, you know, it's a very tough space to stay persistent in. Grania is going to know that my persistence is endless. We really welcome, I suppose, the focus now and the fact that the pilots are imminent. But I suppose I appreciate that the dedicated child health PHN focus will need to be within the broader context of safe staffing. But it'll be much more than a numbers game. And I suppose how can we perhaps best work with you to support you around absolute fidelity to the model and the kind of work that people like Jackie do in the community and indeed your colleagues in Cork that, you know, where you can just go that bit further. It's more than just checking and the KPIs over 5 core visits. It's being able to go back. It's being able to signpost. It's the weaning workshops. It's that parenting, you know, relational infant and early childhood mental health focus so that they're not seen as perhaps, and it's the parent experience, you know, of not perhaps being rushed through, and so that they're not seen as maybe added value and they're seen as absolutely core to what we're trying to do here. So that's maybe one question. And the second question, which perhaps nobody has the answer to, that how hopeful can we be around the resourcing? I spoke with an ADPHN, Una won't mind me mentioning, just at the break, and she just talked about going from very recently, a couple of years ago, having 10 PHNs and 5 RGNs in one of the areas in the inner city that she works from, and now it's 6.3 PHNs. So to achieve a dedicated child health workforce, you're robbing Peter to pay Paul if you're just taking out of that core. How can we, I suppose, influence the pay in numbers situation that public health nursing and this dedicated child health workforce can truly be implemented?
Great, thanks a million. So I'm going to go back to Grania first, and then Becky around the first question, reasonable time frame for both the pilot and then the full health workforce. And I'm going to throw in that last question, which is what's its likelihood in terms of resources?
So when we talk about the pilots, so the research team are currently looking at picking pilot sites. The interesting thing is, I suppose, some areas, like you mentioned, have already moved to a dedicated workforce, dedicated child health workforce in the PHN setting. So there may be some leverage in that. We'll have to leave that to the research team to see what they can do, but we would expect to have some early results by the summer of next year. I know from the first 5, their objective originally was to have it implemented by the end of the strategy, which is, I think, in 2028. Implementation across any change takes time, but I suppose the key part to that is to make sure that we're planning and getting it right at the pilot setting so that we can learn from any issues that arise so that we can actually do a proper implementation plan after that. But as early as we get the results from the research team, which, like I said, will hopefully be at the middle of next year, we will then be able to pull it together an implementation plan.
Okay, great.
So I suppose there's a couple of pieces. I'm really excited to hear about these pilots. It's been really fantastic to hear you speak. There's a part of me that wants to go down an optimistic line of anything is possible in with the recent history of the pandemic. We saw the rallying around particular policy responses and healthcare responses in that respect. There's a lot of emergency policy put in place, a lot of strategies developed very quickly. Certainly with maybe not a kind of consideration for the lasting impacts of these, but I do have that sort of state of mind sometimes when I come to events like this and everyone is working with that same mission. I suppose for me, I think it would be very possible to put it in place by 2028, but I do think there is a necessity of ring-fencing funding. I really strongly feel that the wider social policy context is a thing that is impacting public health nurses in general in terms of their decision to stay, in terms of our healthcare professionals largely migrating and bringing their expertise abroad because access to housing is very difficult to come by. And that question of our health and social professionals being consistently sort of underpaid and undervalued in society. We can value their quality without valuing them sort of economically and financially, and I think that that's a huge issue. The training that is currently available for public health nurses is already very extensive in terms of what they can provide families, infants and children. One thing that I think would be really positive as well in terms of actioning this is sort of fast-tracking specialist training so that there's sort of possibilities of sort of futures for specialist public health nurses within that designated role. I think it is more than possible for 2028, but ring-fenced funding and making these roles attractive is crucial.
Great, thanks. Take that back. And then Jackie, I'm going to go to you just around the, missing low risk, high need, developmental checks, home visits, all of that, just to talk a little bit about that.
You struck a chord when you said about a child in homelessness who wasn't seen, and I would hope that there are ways of that shouldn't happen. That's not acceptable, and I think there's certainly things we can do about that. Certainly that happens. Public health nurses often see children and they're on waiting lists. That's a problem. And I did say earlier on, we need those extra specialists as well. We need our physiotherapy. We need we need that multidisciplinary team when we're addressing children. But I suppose I'm going to also just say that you know, we're talking about the like the lack of public health nurses in areas and where we don't have and you can't access, and parents have to, you know, ring in and make complaints, etc., etc. But I was in UCD yesterday with some of my colleagues. We were doing the child and family health needs assessment with our public health nursing students. And to say there was a vibrant group there, they were just so committed, so well educated, so well trained, ready to go, ready to rock and roll and see families and children. You know, that was just really encouraging. And 8 of those children, 8 of those public health nurses are coming to my area. Last year I got 2. This year I was really worried that I wasn't going to get any, but there was a slight change, and that was that the public health nurses, as students, were going to be paid. So that made a difference already. The year before that I had 2 students, and they came from the UK. So, you know, I think we certainly can. It isn't rocket science. We will get public health nurses, and there are plenty of them out there. You know, and I don't think it's going to. It is a problem in certain areas, absolutely, and I'm well aware of what's happening in Una's area, etc. But the north side of the city, we have public health nurses. We just don't have community RGNs in the community, and we need more community RGNs. We need to develop pathways for nurses in the community and build up a really vibrant team. We're on the cusp of that. I don't think it's going to take a whole lot. It's just really about dedicating, and then we'll be able to see and support our children. But we also, as I said, we also need those therapies as well. You know.
Yeah. Can I just add to that? I mean, it's actually one of the best jobs, right, in the nursing profession, and it's so meaningful and so diverse. And I was just thinking about, you know, the best practice models about how do you build the workforce, and you mentioned that the trainees are paid. So I know one of TUSLA's big success stories has been that UCC programme, where effectively they're trainees and they're paid to become social workers, because they realised one of the barriers for becoming a social worker was you have to go and do a degree, it's expensive to take time out, and a lot of people who choose to be social workers, they might have done another career and they just can't afford it. They can't afford it. They've got families and houses and mortgages to pay for. So those kind of models actually work, and I suppose we need to invest and expand on them, and we'll get the workforce that we need, notwithstanding the issues around housing and everything else. I think there is a solution to those problems. They have done it in other countries where they've supported housing options as well for some of those key professions. We should be exploring all of those things in this area.
Can I just add something about children and homelessness? I was that child as an 8-year-old child in one room in a B&B with my brother and my mother. No child should have to accept those circumstances ever. And so to see children in long-term homelessness, in homeless hubs and temporary accommodation is not a solution for child homelessness. And I suppose the other aspect of that is the transient nature of that. And thank God you were there to pick up on that child. But there needs to be much more work done between local authorities and I would say public health nurses, to really track those families. And I know there is a lot of work being done on that. But if children were in communities where their social networks are, where their doctors are, where their public health nurses are, where their schools are, their teachers, you know, the community resources, there will be less likely that they will slip through the net. So I just want to say that it's not acceptable. And I suppose one of the things that we can do, I think there is about, is it 2,500 children in temporary or homeless accommodation? 2,500 children, families, I beg your pardon. This is not an insurmountable number of families, and they must be prioritised out of transient homeless housing. It's an emergency to have any of those children for any period of time, and I just think that's possible. I don't think we should be accepting narratives of complexity. Prioritise those children and bring them back to the communities, which in other kind of decades and times they would normally be in, and bring them back to those networks. It's so important for their development and their futures, and as well for, I suppose, us as adults to see their capacity. I suppose sometimes we hear, and I suppose not from the people in this room, but adults teaching in the professions and all the professions, where we perpetuate a kind of a narrative where children aren't going to make it, that they don't have the opportunities or they don't have the capacity to make it and to reach their potential. And we should believe that every child should reach their potential and have the, I suppose, potential to kind of work through the best of life. And those children shouldn't be written off so early, and we have to make sure that everybody with a public sector duty has a focus on children as well. I think that's really important.
I think we'll have to give that a round of applause. Thank you for sharing that and for those really pertinent points. We're actually coming to the close of this, so you're not too far between your lunch. So I'm going to ask the panel just to briefly give us one takeaway from today. Do you want?
Yeah. It's a huge question. I think it's been really motivating day. I'm feeling very moved, actually, to tell you the truth, by the panel discussion and by the presentation earlier, just by the energy and advocacy that is going on. I suppose the single takeaway would be that political action is impactful, and that is both speaking about the governmental level, but also the politics of the work that we are doing. It is really meaningful to think about these things. It is meaningful to act on these things. So that would be my takeaway.
I suppose on behalf of public health nurses, it's great to be heard. Because often we're not, there's not a whole lot of us here today either, so it's just great to be heard. And obviously on behalf of families as well and colleagues, it's great that we're here together, working together, because I believe there's huge power in working together. That's what I've always maintained, as anyone that knows me knows that. There's no point in any of us working in silos. We work together and we complement each other. That's really important. Thank you, and thanks for today. Thank you.
I just want to say I think we have all the ingredients to get this right, and I love the way that you've put on the 2028. I think maybe that's a good marker for lots of us to kind of coalesce all of these different kind of pieces of thinking. I just want to mention some of the things that I think we could build on. In Cork, we are a designated World Health Organisation healthy city. Limerick, Galway, I think Waterford are also designated. We're building child-friendly cities in Cork as well. And of course, we have the area-based childhood programme. We have the expertise of the Prevention and Early Intervention Network and their membership, and we have FRCs. We have skipped over I suppose, the pilot period. There are PHNs already working in the dedicated roles. And these are and we have real leadership in the likes of Louise Gibson, like pushing things and not waiting for policy. And I think policy needs to catch up with where everybody else is kind of at, I suppose, is what I'm saying. And we now need to spend maybe till 2028 to pull all that together. And I'm just really motivated and excited to hear from everybody today.
Great, thanks a million.
Thank you. I was really obviously excited to see Professor Marmot speak earlier, but I'm kind of on the same page as Tanya in proud of how well Ireland is doing. We know we're not there yet, but we have gone a long way towards, I suppose, addressing the issue of child poverty. And, with this momentum in the room here and in all government departments, we can continue to do that and just get better and better and maybe give Denmark a run for their money.
Yeah. Great, love to hear it. Tanya, last but not least.
So let's give Denmark a run for their money.
Yeah. Brilliant. So my last task then is to thank our wonderful panel, to thank you all for being here, and also to thank the Children's Rights Alliance. My takeaways really from today, I suppose, is that pride in Ireland, and now we've got a target of beating Denmark by 2028. So that's a fairly significant takeaway. For us at Community Foundation Ireland, and I'm sure you'll hear from Cleala later, but just a commitment to where we might be able to play a role and how we can continue the work. Really excited of the work that's already happening, and then to listening to the professor this morning, just that there are sites in Limerick and Cork while we're trying to systemically change the national policy. But I think the takeaway that I'm going to steal or borrow, isn't that the term, is hope is the opposite of fear. So I don't have to be a pessimist or an optimist, I just have to be hopeful instead of fearful. So, Garamila Mohagweb, thanks a million.